Good morning. It is April 16, 2026 at 9:02 a.m. The board meeting
Recording in progress.
I'm just going to restart. It is April 16, 2026 at 9:02 a.m. The board meeting of the Oregon State Board of Nursing is now called to order. A notice of the board meeting was published by Richard Prusak, Executive Director, in accordance with the open meeting law. If necessary, the board may also meet in executive session as authorized by ORS 192.660 subsection 1, ORS 192.660 subsection 2F and L, ORS 678.126, ORS 676.165, and ORS 676.175 subsection 1. Board members and staff stating that they are present are attesting to understanding the confidentiality of executive session and have taken steps to ensure that the executive session proceedings are not observed or heard by anyone not authorized by Public Meetings Law, ORS 192.660. Is there a roll call by Secretary?
Yes. Oleniki Toabola.
Present.
Margaret Hill. Present. Claire McKinley. Yoder. Present. Rachel Dennis. Here. Felipa Nesta. Here. Rachel Mitzel. Here. Matt Calzia.
Here.
There being a quorum present, I declare the board eligible to conduct its business. Do we have a roll call by Executive Director?
Yeah, good morning, everyone. Happy Thursday. It's been a long week together and happy to be here. I'd love to start with our policy analysts and have them say their name and that they're present. We'll come over here and then we will bring the mic around to our staff and guests. So please kick us off over there.
Good morning, Michelle Bell, OSBN Policy Analyst.
Laura Blackhurst, Policy Analyst.
Gretchen Cook, Policy Analyst.
Sarah Wickenhagen, Policy Analyst.
Barbara Holtree, Communications Manager.
Kimberly Goddard, Chief of Staff.
Rachel Prusak, Executive Director here.
Brandy Ritter, Executive Assistant.
Amanda Musin, Operations and Policy Analyst. Nicole Van Winkle, Policy Coordinator.
Sonia Holtzman, Contact Center Supervisor.
Erin Ferris, Investigations Manager.
Christy Zimla, Oregon Nurses Association.
Joanna Russell, Sumner College.
Phil Young, Board IT Staff.
Sam Fontenot, IT Staff.
Thank you, everyone. And Madam President, would it be okay if I took a point of privilege and made a suggestion that our new board member introduce themselves? I know we don't usually do that on Wednesdays, but it'd be great on Thursdays to be able to do that. And
Yes,
we kick off. Thank you. Sorry, Matt.
I'm Matt Calzia, registered nurse from this Eugene Springfield area, work in acute care setting, and thankful to be here. It's been a great experience so far.
Thank you. We're going to start off with the consent agenda. And I know we're all trying to clarify page numbers on the packets, so we should be going with not the addendum packets, but the Titled 1, April 2026 board binder secured with comments. And I'm just trying to scroll down to what page number?
134.
Should be on one.
I'm glad I was not the only one having challenges.
No.
With it.
Does yours match?
134.
Mm-hmm. Yes, no, it should be. All right, are there any questions on the consent agenda, or do we have any questions before we get a motion? No? Who, are you making the motion, Executive Director?
Sure thing.
Thank you.
Yes, I make a motion that the board vote to approve the consent agenda.
So moved. Second?
It's been moved and seconded. Let's do a vote. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis.
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
Yes.
Philippa Nesta,
Yes.
Oleniki Tolbola.
Yes,
The motion is passed.
thank you. Then we'll go to approval of the board meetings on 145. Any questions on that? Do we have a motion, Executive Director?
Yes, thank you, members of the board. I would like to make a motion that we approve February 18th and 19th meeting minutes.
So moved. Second?
It's been moved and seconded. We'll do a vote. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis.
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
Yes.
Philippa Nesta,
Yes.
Oleniki Tolbola.
Yes.
The motion is passed.
Next, we'll have our policy analyst coming up.
Good morning, members of the board. My first item today for you is related to administrative rulemaking. I believe this is on page 165 of your packet. And it is regarding permanent rulemaking in Division 21, our standards for the approval of nursing education programs. Since the February board meeting, we held a public rule hearing on March 18th and did receive testimony both in support and opposition to the proposed rule change. One thing I want to elevate for the board is that, again, what we're considering today is no longer requiring that all education at the APRN level be required to be a doctoral degree. And one of the things we considered in our analysis bringing this forward to you all is that no state in the US requires all APRN education to award a doctoral degree, and only a single state carves out CRNAs. And so in bringing this forward, I want to highlight that there are other mechanisms in our Oregon Nurse Practice Act that do ensure these programs are accredited, that the graduates of these programs will have to hold national certification. And so there are other layers of public protection and national standards being applied to these programs, even if it's not the degree awarded itself. So I would love to answer any questions you have about this change or any of the testimony, or bring a motion if you feel ready.
Thank you for the work on this, policy analyst. Do we have any questions since we discussed this before? I think we're ready for a motion.
That was easy. I motion the board approves the permanent adoption of proposed amendments to OAR 851-021-0050 as presented effective May 1st, 2026.
So moved. Second?
It's been moved and seconded. We'll vote. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis.
No.
Lee Yoder, Rachel Mitzel,
Yes.
Philippa Nesta,
Yes.
Oleniki Tolbola.
Yes.
The motion is passed.
Right. My next agenda item for you all, this can be found on page 209 of your packet. It is regarding a continuing approval survey from Treasure Valley Community College's registered nursing program. And I have Mara Pointer, who is the nurse administrator, online. Treasure Valley is in Ontario, Oregon, so quite a distance for her. This program underwent a survey in February 2026, which was conducted alongside their accreditors survey. The findings are attached in the packet. You will note that there were several items I had evaluated as partially met and gave recommendations, and then a small number of items that were evaluated as not met at the time of the survey. I do have verbal updates to share with you all because I really want to commend Mara and this program. They took the feedback that they were given and have already started to make changes and share those updates with me. So as I go through the standards that I'm evaluating as not met, I'll share the updates. And then I think I would like to discuss with the board maybe a different approach given the work they've already done. So the standards that had been evaluated as not met were related in Division 21 to rules 00458, which was about nursing faculty, oversight of students in clinical, and really having policies that support safe supervision of students. The program has now developed a policy. It is documented how students are assigned, how they're supervised around clinical placements. They have ratios now in place. The next standard I had evaluated initially as not met was related to Rule 00553. Again, the program needed a policy around their LPN to RN bridge, something that really clearly showed how the bridge students, what courses they take, how they are evaluated, how we make sure they still meet program outcomes. And since last week, the program now has a very clear policy, a very clear information about the exact courses these LPN to RN students take, how they're evaluated to meet program outcomes. And then the third standard I had evaluated as not met was related to Rule 00653. Again, needing a clear written criteria for how clinical sites are selected for students. Something that considers level of student and learner. Again, they have now a policy that is very clear and robust about how they select clinical sites. And so I really want to commend their work and then discuss with the board what next steps to take. Initially in my memo, I had requested the board to find some standards deficient and require the program to issue us a follow-up report of how they're addressing the standards. But from what I am seeing, they've actually done that work already. So I will pause and open up to questions. If there are no questions, then my recommendation would be that the board just grant continuing approval to this program.
They must have a very motivated team of faculty members to get this done so quickly.
They do. Mara and her small faculty team are very dedicated to the work that they do. It was very impressive to have updates to share with you all.
Thank you. Thank you very much and for the prompt response and attempting to update and fix this deficiency. My encouragement will be to continue to find ways to improve your programs ahead of time and continual process improvements to identify possible deficiency ahead of time so we can give our nursing students the best experiences. Otherwise, I think we're ready for a motion.
Then I motion that Treasure Valley Community College's pre-licensure registered nursing education program be granted continuing approval with their next anticipated survey aligned with future accreditation surveys.
So moved. Second?
Been moved and seconded. We'll vote. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis.
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
Yes.
Felipa Nesta.
Yes.
Oleniki Tobola.
Yes.
The motion is passed.
Okay, thank you. 1 second. All right, my final education item today is on page 219 of your packet. This is regarding a survey schedule for Sumner College And I'm very grateful we have a guest. This is Jana Russell. She is the president of Sumner College, representing today. So for this item, as I discussed in the memo, the registered nursing program underwent a survey from their accreditor, CCNE, and unfortunately, OSBN was not on site at the time of the survey. And so I'm looking for board direction on how to proceed. I have the delegated authority to flex survey scheduling to align with national nursing accreditation surveys, but because theirs was just completed, I believe they're not anticipating another survey for several years. And so my recommendation now would be, since we did not have the opportunity to survey while the accreditor was there, that the board authorize a survey as soon as possible so we can get that done and stay roughly on track with our evaluation of the program. And then happy to take any questions.
Just out of curiosity, how recent was the survey?
Oh, sorry, March 2nd, 3rd, and 4th.
Thank you.
We have not received our final report. It may take up to 8 weeks, but we did receive our verbal exit. And I have the 2 areas. We do apologize. We did not know with the rule changes. I was reading the first, because we're a new nursing program with the BSN, even though we've had our RN since 2012, I thought a site survey was required, but there's 2 different areas, and our department chair thought it was a site survey after. So as far as our areas of concern, it was standard 1, IE, and it's faculty and students participate in program governance. They're requiring follow-up because of the students' participation. They are part of our advisory board, but they wanted additional student participation. So we've created a student meeting that's quarterly, and our first meeting's May 5th. So that was one area, was just student participation. The second area was standard 3H, and we have to submit a table that outlines term by term with clinical experiences. So those were the only 2 areas. There was nothing in, no non-compliance as far as curriculum.
Thank you. Do we have any question? So I think it'll be helpful if we can try and do the survey as soon as possible. That way we keep in alignment. And also, since they just prep for that, they want to have a lot of prep work if there's no long lag in between. Are we ready for a motion? I think we are.
Then I motion the board direct a continuing approval survey of Sumner College's pre-licensure registered nursing program.
So moved. Second.
Let's pause. Are we approving, or we're motioning to designate continuing approval, or are we doing
Oh,
the survey?
Thank you for clarifying. My wording was direct a continuing approval survey of the pre-licensure registered nursing program.
Thank you. All right, could we do it again?
From
One
the
more
top.
time? Yes.
I motion the board direct a continuing approval survey of Sumner College's pre-licensure registered nursing program.
So moved. Second.
It's been moved and seconded. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis.
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
Yes.
Felipa Nesta.
Yes.
Oleniki Tobola.
Yes.
The motion is passed.
Thank you. Those were all my items for today.
Thank you. We're a little bit ahead, so since we kind of had a rough start first this morning, can we take 10 minutes to reset?
Yes, please.
Thank you.
So, Madam President, we'll be back. Do you want to say at 9:30?
Yes, be back. Welcome back. So we're gonna pick up where we left off. And I think we have Executive Director next.
Yes, members of the board, I would love to direct your attention to page 219. So as you know, agencies can bring legislative concepts to the Oregon legislature, and timelines are very interesting. They are now for the 2027 legislative session. And so I wanted to bring these concepts before you. There's not a motion to vote. There's just me presenting to you concepts that I've heard you all have discussions about, or things that I know from leading the agency, national discussions. And so they are here before you, starting on page 219. We have one to discuss renewal date alignment. So prior to January 1st, 2026, OSBN statutes tied renewal dates to the licensees or certificate holders' birthdays, which sometimes resulted in individuals receiving a license or certificate for less than full 2 years before their initial renewal date. And I know this was discussed on our strategic planning day. And then our legislative modernization changes shifted renewals to the issue date, ensuring that all new licensees and certificate holders receive that full 2 years for equity. But what we found on implementation is that created challenges for those holding RN and APRN licenses. So they're not automatically aligning. And so if we were able to amend ORS 678.101 to give the board authority to adopt rules that allow applicants to request aligned renewals and provide flexibility to synchronize applicant renewal dates for those that hold multiple license and certificate, it would be a smoother process. Are there any questions on that concept?
Yeah, so you're wanting to have it so that people will have to apply for it instead of it just like automatically happening, is that correct?
So what we're looking for is actually rulemaking authority, so the board can put it in rules and if they won't have to come every single time for alignment, and we can address that through rules. Right now, the statute's very prescriptive,
Mhm.
and so it's each license is tied to the issue date.
Yeah.
And if we can put it into rules so that those that have multiple licenses may be aligned, then we'll be able to, address that without coming every single.
Okay.
Yeah, and how we specifically do that, we would come to the board during rulemaking, have those discussions, and you would all
Right.
finalize.
Okay. Cool.
Great. Okay, I'm going to move on to the next one, which is education flexibility. So currently in ORS 678 point, oh my God, I'm wearing someone else's readers. 3603 directs the board to issue written notice specifying identified programs deficiencies and providing time to fix them. ORS 6783, is it 6 or 5? 604 directs the board to revoke institutional approval for programs that fail to correct deficits. There is no flexibility to account for the severity or nature of deficiencies, and the requirements to close them could cause significant harm to students. Amending OR 678360 to specifically call out the board's authority to issue a plan of correction and removing the mandatory language in 4 and replacing it with permissive language will allow for board discretion. Secondly, the current statute does not provide explicit guidance on how the board should handle complaints regarding educational programs. To address this vagueness, amendments are needed to clarify that ORS 676165 and 676175 apply to nursing aid, and medication aid programs, and clarify that the confidentiality of information discussed in ORS 678.126 extends to education programs, establishes a range of sanctions beyond removal of program approval, and differentiates between surveys and targeted investigations. I know this is something that we've been talking about since I arrived to the board, this kind of all or nothing. And I think this is going to really open up that flexibility to allow the board to create rules that's really going to support our education surveys. Any questions on that? And I may invite policy analyst Laura Blackhurst up to support me in that.
Can you provide an example, like the first paragraph there, like deficiencies that were so terrible that they couldn't get these corrected within a certain time frame, or what does that look like?
I don't believe we have an example of a school that did not correct deficiencies, but the statute does direct that if a school does not fix a deficiency that the board identifies, we must revoke approval from not just the program, but from the entire institution. And so that does not allow the board to really consider the nature of the deficiency. As we saw from our discussion earlier today, sometimes the deficiency is that they're just missing a policy, but sometimes the deficiency could be related to safety, oversight, supervision of students. And so we really just don't have flexibility for the board to consider the difference in the type of deficiency from a program. But to my knowledge, we have not had a situation where a school did not have a dire safety issue that was not addressed.
And maybe further clarification you could provide that might help. I think one of the things that we talked about is how all of the statute updates we're doing is because it was a patchwork of statutes over 70 years and some antiquated ways of how nursing education was done. And I think when it says institutions, it doesn't say programs. Is that, I don't know if there's anything you want to say to that too, but.
Thank you for highlighting that as well. The statutory language again does say we revoke approval for the institution. Now, an institution might have multiple different nursing programs at different levels, and those other programs might not actually be out of compliance with the standards for approval, but yet our statute directs the board must revoke approval for the institution, which could be really harmful to these other nursing programs within the same institution. Again, especially if they are fully compliant with the standards.
Are there specific timeframes to correct specific types of deficiencies?
The board always has the opportunity to direct the timeframe. So typically, when a policy analyst such as myself brings a deficiency forward, usually I'll have a motion that includes the recommendation of, we want to see evidence of this corrected within 6 months or 9 months. And I believe we've had conversations in the past at board meetings about, again, the nature of the deficiency and what is a reasonable time frame to correct. So it's not, the time frame itself is not prescribed.
And then lastly, do you, is there middle ground? Like, do programs go on probation before you just revoke?
Great question. We do not expressly have that authority to put a program on probation. It is an all or nothing directive in statute.
I appreciate this flexibility because I think that there are so many things that can go into a program having some sort of a deficiency, and that time piece, depending on what it is, it may take a cohort of students going through to show that, like, okay, we have fixed this issue. So I appreciate the flexibility. And I was here, I don't know when, it was like within 10 years, and there was a program that shut down, and it wasn't the board that did it, as far as I know. I don't think the board did it, but those students were really, students invest a lot of time and money, and then they're saddled with the debt if a program closes like this. So I appreciate the flexibility for us to maintain safe programs and to rectify deficiencies.
I think it's going to really help the agency as a whole as well, supporting when we hear from schools and maybe when we get complaints, really how we're able to address them more holistically. Now having done a survey and understanding really the impact it could have with our all or nothing approach. I truly believe it's going to give the board and the staff that supports the board opportunity.
I was just going to say thank you. It shows that we're constantly involved in improving ourselves and our processes to understand that society keeps changing and the focus population change and the people that are learning are changing and the people that are teaching are changing, to adapt to that and see what's realistic now and what was realistic 20, 50 years ago will constantly change. So I just want to say thank you.
Yeah, thank you. Again, it's, hearing what the board shares with me, but also hearing what our staff shares. And when we're trying to really uphold our mission to protect the public and support our programs, but not always having the tools to do it and having things be the opportunities to work alongside you and improve them. Thanks. Ready to go on the next one? Okay. So OSBN is required by statute to investigate all complaints and every applicant with a prior conviction. As a result, significant resources are spent evaluating both new and renewal applicants whose convictions are disclosed or identified through background checks. OSBN must additionally demonstrate a direct relationship between the circumstances of a conviction and the practice of nursing. This uniform investigatory threshold means that all convictions, regardless of type, demand extensive case-by-case investigations that can take many months and require expert input, including assistance from the Department of Justice. Certain other licensing agencies use statutory lists of disqualifying crimes as grounds for denying or revoking a license, particularly when a profession involves an unsupervised access to vulnerable populations. Nursing professionals serve the same vulnerable groups, often in more sensitive circumstances, yet OSBN lacks similar statutory tools. The current system has created a substantial and unintended resource burden. Establishing a focused list of crimes involving vulnerable populations would allow OSBN to maintain fairness and reduce stigma, promote consistent licensing decisions, safeguard state resources, and strengthen its mission to protect the public.
Can I ask what other agencies use these type of tools?
So specifically, I know teachers' standards. What's the other one? One other one?
Department of Early Learning.
Yeah, I do think
And
this
ODHS.
I do think this one will be maybe controversial if it's approved, right? We bring concepts and the governor's office decides if it's going to go through. And I know as we look towards all of the conversations around kind of rehabilitation and not putting up these barriers, does this cause a barrier? But at the same time, these are like homicide. Yeah, would you like to come up, investigation manager Ferris? I think there's an opportunity here for a discussion of what other boards should have the ability. Thank you.
Yeah, hello again. I was just going to mention that these are usually pretty egregious in nature, person-to-person crimes, homicide, sexual assault, rape, child sex abuse, those types of crimes.
Yeah.
Would the list come to us for board approval, or is that open to discussion?
So typically when these move through the legislative session, I continue to update you all of what it looks like after it's drafted and have conversations and go from there. And again, like the original statute fixes we did were very like black and white. What is old? What do we have to do? These are kind of getting into those next level. And one of the things that I was thinking about of how we could have this discussion is also that there'd be an ability for the person to appeal it, right? Depending on what comes up. But yes, I can share with you all the current statute and the list of the other agencies for future information.
I would just add that some of them, like teacher standards, their list is very extensive. We likely wouldn't seek something that would be that extensive.
Are any other boards currently using a list like this that you know of amongst other boards of nursing?
Oh, other boards of nursing across the nation. You know, I haven't surveyed that, but I will. I will do that. I have a feeling there probably are many boards of nursing that are, knowing the different state jurisdictions with criminal background checks and stuff. So I have a feeling they are, but it'll be interesting to look. And again, these are concepts. I don't know what will happen. But I really do think, you know, being here for almost 3 years, witnessing the resource burden on our investigation department, and as you all know, what we bring to you, I think that it could benefit, but I do think it's going to be a conversation at the legislature.
I would offer that when we're looking at these types of crimes in relationship to nursing, the practice of nursing, we have to tap subject matter experts, and finding certain subject matter experts on, say, sex crimes can be really difficult because it's not something that we can expound on ourselves. So it's a resource pull on that. There's a fiscal resource pull because we then have to pay those subject matter experts for that consultation. They tend to, on average, take a lot longer than the other investigations that are open as well because of that consultation that's necessary.
Out of curiosity, I know this is concepts. Is it forward-facing concept, or is the list going to be forward-facing? Like in the
would
last
be in
5
stack.
years, have you been, okay.
Mhm.
That helps a lot.
Well, since we're just sort of floating ideas, I mean, to me, someone who's committed fraud, healthcare fraud of any way would be a disqualifying for me.
I can look and see if that is, can survey that as well and see if anybody is doing that. I know that's coming up a lot.
Yeah,
When reviewing other lists, that we did see that there was certain financial crimes that were listed on some of these disqualifying crimes.
good, because even just last board meeting, there was
Careful.
things that were like, wow.
And on these lists, would there be kind of like a time, well, some of them obviously wouldn't want a time limit, but like I would hate to see someone who, you know, had some kind of like crime in their past when they were like a young person, and you know, it's 20, 30 years later and they're like, I am a completely different person than I am now, or than I was then. Like, here's where I've changed. Would that go into like the appeal process then? Or we're looking at maybe doing some kind of.
I don't know that we have an answer to that just yet. Of course, we always consider the nature of the crime, the age of the crime. Those are things that we already consider, especially with juvenile adjudications. Those records are sealed. We often don't investigate that, depending on the circumstances. But yeah, I think once we get further into this process, we can evaluate the appeal process.
Yeah, and the way that it works is we submit legislative concepts. The lawyers at the state look to current statute and other areas of our law, and then that starts the conversation. But as Investigation Manager Ferris said, we do really do that now with everything that we get in our applications, and feel the same.
I don't know if it's just me thinking this, but it feels like this ties into predetermination. And it will make a lot of sense, like having this in place. We're going towards predetermination route so people can have a good idea ahead of time and don't make it to the end and then say, well, that was a lot of money wasted for nothing.
Agree. Okay, I'm going to move on to the next one. So many of you heard me talk about this last time, board expansion, and I actually submitted that legislative concept and then killed my own legislative concept, our own legislative concept, because we were so busy updating HPSP and doing that technical fix and all of the other opportunities that OSBN had engaging in the legislature that it fell down the list of priority. But you know, you all know that I had shared with you in 2023 that the Oregon Healthcare Association really looked to update ORS 678140 and added this third factor for the governor to consider when making appointments. And it says, for the members who are nurses or are a certified nursing assistant, the setting in which the member practices nursing or provides care with priority given to members who practice or provide care in facilities or other locations that are licensed by DHS or the Oregon Health Authority. In simpler terms, that's community-based care. And this is how we have Linda on our board, who sadly has been pulled into a survey the last 3 days. But what was interesting when we were looking at this and exploring how do we make sure this is taken into consideration, because nurses in long-term care, community-based care have such an interesting role where they're not just providing bedside care, they're also providing administrative duties. It was considered, no matter what, the administrative position on the board. And so that's how that happened. So then we have this, will we ever have that, you know, kind of hospital administrator be able to be here? How will we balance that? So that was the conversation I brought and wanted to say, how do we ensure that there's a community-based care nurse always? I think all of us can attest to the fact that it's been very helpful for our board, and not just have it be taken into consideration. I will say that Oregon Nurses Association reached out to let me know that it is something that they are interested in doing. They're, you know, they're in the process right now of their policy cabinet, figuring out what they will be bringing and prioritizing. Excuse me. And so that was good information for me to hear, knowing that they also were really interested in this. And so what this would do is ensure that a community-based care nurse could always be on the board. We'd still have the administrative position back. And then for the other role, I know we had conversations about a third public member when I was thinking about doing this last time. But really reflecting on our numbers, and you know, we talked about them during the strategic plan. When we only had one APRN, it's actually listed as an NP because at the time there weren't all of the APRNs, there was the NP. And we've had APRNs wanting to be on the board. So those are your CRNAs and others. And so they have not been able to. And so this will allow us to add on an APRN. And I think we're at, I don't have the numbers in front of me, but we looked at them. What are we at? Like 9,000. And we were at a couple of, oh yeah, maybe even higher, 12,000, thank you. 9,000 is probably the MPs. And when we started this, because I brought the numbers up the other day, there was, you know, a couple of hundred. So we really should have that representation, and hearing from APRN communities who haven't been able to sit on the board because it specifically says NP, updating that would be the recommendation I would have for the board to discuss. So those would be, that would be the board membership, expanding you to 11 and adding those two. Any thoughts?
So I was just running the numbers because I was thinking about this. And so currently, of the nurses or of the people that are licensed or certified by the Board of Nursing, APRNs make up about 9%, whereas RNs make up about 70%. So then this would mean that APRNs would, if we had two APRNs, they would make up, I think, about 18% of the board. So that's quite a bit more than their representation. And then nurses, although they make up like the vast majority, they only make up about 36% of the board. I don't know how we're counting, you know, who is in what role. And so I counted Linda as an RN. So I was just thinking, you know, it seems like that like the RN role is underrepresented on the board. So I just wanted to bring that for discussion. I can think of multiple different things. So for example, APRNs are also RNs, but they're also bringing a different perspective because their role is different. And so anyways, I wanted to discuss that.
No, I appreciate that. And think that, again, The concept is to expand, making sure community-based care, but I think the discussion about what that other role would be is still one we really do need to figure out. I'd love to hear, thank you for that.
And I definitely am passionate about this particular topic because before I became an NP, I was definitely excluded in board participation. And I don't think that really fits our mission as a board for APRNs. I don't actually quite understand, and maybe you can help me understand like why it was limited only to NPs and not open to all APRNs.
So and that's why whether we add another APRN or not, we still should change the language because NPs are APRNs, but it's because historically, and this is what we discussed at the strategic plan, right? In 1990, there were 661 NPs. There weren't any CNSs, CRNs here. So that is probably part of how that happened in the statute when ONA led on putting in statute the descriptions. So that's probably how that happened. And that's why I think whether we add another one or not, it could be APRN, right? So that, there's only 100 and something CNSs on, here. So, but it does open it up to say NPs and CRNA.
Could we also, if we don't go with the additional board member as an APRN, could we change the
Yes.
existing language?
Yes, that's what I'm
for the
thinking. Either way, that is what I would want to do. I think that we should do as the board, knowing what I have witnessed just being here for the last few years, people wanting to apply, including conversations we had. So before you were a psych NP and CRNA. And I think the CRNAs bring a great perspective. So either way, changing NP to APRN should be part of that discussion for us to lead on. I keep saying me. I know that it's us.
I would appreciate McKinley Yoder's comments, and if we're trying to do more percentage, which makes sense to me, so I really appreciate that, and I would agree with that. One thing to consider is, we have a nice sized board now, we have nice discussions, and when boards get larger, it's a much more clunky creature. And so I would put caution on expansion.
As the director that reports to you all and wrangles you all the time, I completely think that's probably why I dropped it the first time when I was advocating and hearing you, just full transparency. And I did do a survey too to see what is the size. And, it does seem like 11 is that most common number. What I will do is, I'm bringing this concept to you now because April is here and that is when we have to submit them. But I'm going to do some surveying and do the full percentage to know exactly what it should be. And not say because APRNs have the biggest growth, that's what we need to do. I will do those numbers that I honestly didn't do before.
I would appreciate that. I'd like to know, like, across the country, what size are boards of nursing?
Yeah, they're anywhere from 9 to 15. I know, yeah, no.
Well, and a lot of times when these boards get larger, now they start committeeing. Now these people are on the discipline committee. These people over here do this. So is that the direction that this potentially would go? I mean, I think we really need to consider those things. Right now, we can have pretty open discussions. We openly disagree. I mean, I know I rely on all of my RN colleagues to inform me of the exact role of nursing because I'm not a nurse. So do those discussions go away as this board gets?
Yeah, I think there's pros and cons. The thing about this bill that we'll have a fiscal, and we'll have a fiscal because of per diem and travel. So there's that as well. Now, of course, we've made sure we have the budget for it, working with our fiscal officer. But yeah, again, starting conversations, concept. This is, as you know, a long road. Session starts in January something. I don't know if we have the dates yet. It ends in June. So, but I did want to bring it back for discussion.
I would also be curious to know what the makeup of other boards are too.
Yeah.
Is it equal to their?
Yeah, I've looked into that too, a lot. So what I'll do is I'll come with a presentation on all this information. Yeah.
Thank you.
Yeah, thanks for the discussion. Governance is a very interesting topic. Okay, thank you for that. Thank you for teaching me as well of other things I need to think about as I go back to the drawing board. Okay, the last one. Let me make sure though I didn't skip anything that I had already. Yeah. Again, as we close this conversation, the reason why I do think it's important is that the community-based care nurse will always be sitting in this admin, and I don't want, right? So that depends on who applies, who's the director, I just think we need to think about that. Okay, moving on. Expungement. So disciplinary actions on a nursing license can create significant barriers, damage a nurse's professional reputation, and restrict career advancement. Expungement available after successful completion of probation for substance use disorder or mental health issues would allow licensees to clear their disciplinary records through a legal process. These licensees may petition the board to remove information about their program participation from board's records. The board has discretion to grant or deny such petition, so it would come to you all. It would be for allowing rulemaking. And for boards to enact rules, a statutory update is needed to permit health professional licensing boards to establish rules for licensees who have completed probation. And in full transparency, I brought this in the technical fix bill and the HPS bill, but the way it got included was within the alternative to discipline model, and they don't really need that expungement. And so I started thinking about this as I serve on the National Organization of Alternative Programs Board, and following some of the states that are doing this. And then especially knowing there was a time period we didn't have alternative to discipline. And then some of the things that we're seeing come up at boards of nursing across the country. So that was the conversation I was hoping to start. And again, the law would be that boards can make rules. So every board in the health professional regulatory board would be able to make those rules.
I really appreciate that. I feel like, as board member Dennis said, I think it was you who said earlier, where somebody has something that happened 20 years ago and they have fully, we want human growth. We want people to get past that. And then if this is remaining on their record for the rest of their career, even if they've completely fixed the situation, they may not be able to get jobs. And so I appreciate this option, especially I feel like there's a big recognition nationally about this too.
Just a clarifying question. Is this, so let's say they're on a 3-year probation immediately after that, or is there a time, is there a waiting period?
That would be what you all figured out in rules.
Okay. Yeah,
I was just about to ask that it'll make sense, because I know sometimes we rely on historical background on the licensee in some cases, and to know where our fine line of like after 3-4 years should be fine. I think it relates back to some of our education this week of what is the timeline to say you're okay and you're doing great.
yeah, I think a timeline's important because we're here to protect the public, not the nurse. So
I think that the other important thing is, as Director Prusak said, it would be permissive language. So it would come back to each board to make those decisions and be able to work on the rules as we move forward and implement.
Yeah, and then it would be petitioning you for it. So multiple levels. But I am watching a few states do this, and just, hearing the perspectives and stories being engaged in NOAP of those with lived experience and going through the expungement process for their criminal record, depending on what happened to them. It's been really interesting. So again, concept discussion, all the things that have to lead up to then it would be rulemaking, and then it would be the licensee coming to petition based on that.
I love this idea. I think it's great.
Right.
Excited to do this work.
Right.
Are the other licensing boards on board?
Well, it's interesting because, this was originally a concept brought to me asking with nurse practitioner of Oregon and ONA, bringing it to me. So then kind of surveyed to find out what other states were doing it. None of them were at the time 2 years ago when I brought it up, jumping at it. But we do also have a lot of new knowledge over the last few years and new directors. So it'll be interesting to see, and new boards. So it'll be interesting just to see what happens.
I'm curious, with other boards, like just doing the SUD and mental health, I love that idea. Has there been, do any of them do it for other things? Cause like, I think of times where it's like, man, I really would love to give this person a reprimand for something. But at the same time, it's like, I don't know that it really rises to a level of something that I want to be there forever.
So I appreciate that. And I'm not cutting you off to be rude. I'm just always so careful. I'm like thinking like Ellis here, but, so yes, I would love to have that discussion because, again, some of the things that we're watching at boards of nursing across the country, that are happening, that are certain things that are viewed as punitive. How do we address it? How do we address old things where we may have updated some of our stuff? So, you know, we have been having internal discussions about what we would bring to you all, about what that would look like. And I think that would take me doing some data, gathering data from us historically, and then looking at the nation of what they're doing, and then other health professional regulatory boards, what they're doing.
Thank you. We can move on to the next one.
Thank you all for that discussion. And I have homework to do now, and I'm excited about it. So I think next on our agenda is discussing 2027 board meeting dates. So if you can turn to page 222, it is the best memo that I've ever seen. Please see attached board meeting dates for 2027 to be approved. And on page 224, you can see those dates and look them over and let me know if you have any questions. And thank you to Board Member Kalis for being a planner and letting me know we needed a vote on this.
Sorry, we're having side conversation.
Yeah, I'm
In
bet
relation.
out your calendars.
I was noticing that we have August, and I'm remembering last year we did September.
Yeah, so when we moved this year to every other month, 6 months, no virtual, that's what happened this year, and it would be the same next year.
Okay.
Anyone have any questions about the date? Okay, we might be ready for a motion.
Great. Members of the board, based on the information provided, it is recommended the board approves the proposed board meeting dates for 2027 as presented.
So moved. Second?
It's been moved and seconded. We'll do a vote. Matt Calzia,
Yes.
Rachel Dennis.
Yes.
Margaret Hill,
Yes.
Tony Kalis.
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
Yes.
Philippa Nesta.
Yes.
Oleniki Toabola.
Yes.
The motion is passed.
Thank you, everyone. And I'm going to invite Investigation Manager Ferris up for the third administrative piece on the agenda on page 225.
The second best memo you've ever seen. The memo is available to you on page 225 of your packet. Do you want me to read it out loud? Yes? Okay. On September 18th, 2025, the board voted to delegate the authority to the executive director and investigations manager to sign and issue orders for evaluations during open investigations as permitted under Oregon Revised Statute 678-113 subsection 1. This memo is intended to establish clear objective criteria for when this delegation is used by board staff. The proposed criteria include the following. Any of the following within the past 6 months. Noted impairment concerns within the HR records. Self-disclosure of impairment. Right, thank you. You know, I was squinting and struggling.
Next time, speak up.
Communal glasses. Self-disclosure of impairment, other evidence indicating ongoing impairment, including but not limited to arrests related to substance use, positive toxicology during OSBN investigation process, failed monitoring in another state. These criteria are intended to promote consistency in the decision-making while also allowing for timely resolution of investigative process. If a matter does not meet any of the above criteria, but otherwise raises concerns about the individual's ability to practice nursing with reasonable skill and safety to patients, the matter will be brought to the board for consideration.
Just out of curiosity, was there any reason why we put it as 6 months?
Great question. I was asked that by my staff as well. We just wanted to ensure that when we use this delegated authority, that we aren't using it on something that is antiquated or old from an evidence perspective. We wanted to make sure that we're using this serious authority that you have delegated to us in relation to current concern. 6 months felt appropriate.
Thank you.
I was just noting that it says noted impairment concerns within the HR record. And so I was wondering if you could give any clarification on, because I know that sometimes there might be, a colleague said, I think this person might be impaired. Like that might be in the HR notes versus multiple people identified impairment. The person left before they could do a for-cause test, something like that. So I'm just curious, like where that line.
What that threshold is.
Yeah.
Yeah, I think it's usually, I treat it from a totality of the circumstances. So it wouldn't be that one person thought the licensee was impaired. It would be what other indicators do we have present? Have they had a recent arrest? Do we have the manager or the supervisor noting concerns as well on top of their peer that's making these comments? Was there an internal investigation by the employer? Because we take those pretty seriously as well. Yeah.
This is just a technicality, but it says the safety to patients, and it seems like the NPA refers to clients.
I think we're referring to the language that's within the Oregon Revised Statute. But thank you, yes.
Any other question? We might be ready for a motion.
Okay. I motion to adopt the criteria as proposed for the exercise by the executive director and investigations manager of the delegated authority to identify the type of evaluation and sign and issue orders for evaluations pursuant to Oregon Revised Statute 678-113 subsection 1.
I'll move. Second.
It's been moved and seconded. We'll do a vote. Matt Calzia,
Yes.
Rachel Dennis.
Yes.
Margaret Hill,
Yes.
Joni Kalis.
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
No.
Philippa Nesta,
Yes.
Oleniki Tobola.
Yes.
The motion is passed.
Thank you.
So, board members, it looks like we finished 15 minutes early. We do have the public forum from 10:30 to 11, which we have to have, although we have nobody signed up. So we could also, potentially continue on with our items if no one is arriving, but leave it open if somebody does. And then really, it's lunch and lunch presentation. We really had a short, so any recommendations for how we proceed?
Keep going.
You don't have anything else though, except for
What about the addendum agenda? Addendum.
addendum. We do. Yeah, let's do that. And again, we will announce at 10:30 the public forum in case somebody joins. You've said what you need to say and then go from there. Thank you.
Board President, members of the board. Page 229 is from the board packet is what I'm referring to. Applicant Ray Montez has applied by endorsement to be licensed as a practical nurse in Oregon. They passed the NCLEX on June 18th, 2007, and were licensed in California on August 13th, 2007. Based on the information in nurses and provided by Montez, they graduated from the Institute of Medical Education on April 6, 2007. Montez was unable to provide transcripts of their education to board staff during the program being closed. Board staff were able to confirm with California Board of Vocational Nursing that the Institute of Medical Education was an approved program and that Montez graduated on April 6, 2007. Due to the closure of this program, Montez is requesting an exception to OAR 851-031-0039 sub 2A. An official transcript that includes the degree, certificate, or diploma awarded, the graduation date, and the documentation of clinical component as defined in OAR 851-006-0030.
Do we have any questions?
Yes.
Just assuming this school wasn't one that was like a Nightingale school or anything.
No.
Okay, yeah. I don't have a list of them memorized.
No, it's not.
Any other questions? I think we're ready for a motion.
Okay. Based on the information presented, the board grants Ray Montez an exception to OAR 851-031-0039 sub 2A as presented.
So moved. Second.
It's been moved and seconded. We'll do a vote. Matt Calzia,
Yes.
Rachel Dennis.
Yes.
Margaret Hill.
Yes.
Joni Kalis.
Yes.
Claire McKinley Yoder. Yes. Rachel Mitzel.
Yes.
Philippa Nesta.
Yes.
Oleniki Toobola.
Yes.
The motion is passed.
The next one, page 230. Applicant Ma Consuelo Tan has applied by endorsement to be licensed as a registered nurse in Oregon. They passed the NCLEX on September 15th, 1995, and were initially licensed on October 24th, 1995 in the state of Illinois. According to Nurses Education Report, they graduated from University of St. LaSalle in the Philippines. Tan has 2 active registered nurse licenses in Illinois and Nevada. Tan was able to provide original transcript from the University of St. LaSalle and the first page from the Commission on Graduates of Foreign Nursing from 1994. But it was not complete credential evaluation. Tan has been licensed and working within the United States for 31 years and no longer has family within the Philippines anymore to help complete a new credential evaluation. Tan requests the board accepts the original transcript as evidence of completing their nursing education program, which documents both theory and clinical hours. Due to the challenge of obtaining a new credential evaluation, Tan is requesting an exception to OAR 851-031-0039 sub 2C. C states that credential evaluation for graduates of internal nursing education program that does not have an NCLEX code, which includes A, confirmation of completion of a nursing education program approved by a appropriate regulatory body, B, theory and clinical hours completed, C, verification of the education is comparable to an Oregon nursing education program, and D, if available, licensure details from the issuing authority. Any questions?
Thank you. Any questions?
I do. So why could this individual not get a credentials eval CogFins? I mean, he doesn't have to be in the Philippines to do that.
Yeah, go for it.
I'm just going to give a realistic perspective because I have done transcript evaluation with friends. Certain countries it's hard. So even though you use a company called West here, you have to physically have somebody go to the provost in the university to ask for your transcript, or you have to fly down there. Because they would not just leave it out because they charge money and they take more money. And sometimes they just don't keep records well. So you have to know somebody to get your records. And it takes a long time.
It does. And yeah, like you said, it's some of the documents are not electronic. Yeah. Yes,
Especially 31 years ago.
exactly.
It will be in the wind.
My other question, there might be more, but so he has licenses in 2 other states, but is he actually working?
From my understanding, my recollection, they are working. But I don't quite remember the specifics.
Okay, thank you.
So technically, are they applying for endorsement here?
Yes.
Okay. Yes.
Yeah, they have an active license.
Okay. Any other questions? No, we're ready for a motion.
Okay. Based on the information presented, the board grants Ma Consuelo Tan an exception to OAR 851-0031, 851-031-0039 sub 2C as presented.
So moved.
Second?
It's been moved and seconded. We'll do a vote. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis,
Yes.
Claire McKinley Yoder, yes, Rachel Mitzel, Felipa Nesta,
Yes.
Oleniki Tobola.
Yes.
The motion is passed.
I'd like to draw your attention to page 231 for our predetermination petition. So the petition listed below was reviewed by OSBN management, and after review of the documents provided from the petitioner, this predetermination shall be approved once ratified by the board, as the convictions are unrelated to the Nurse Practice Act or lack of jurisdiction, and it is listed there. A really interesting process to work with the board's directors as we have moved through this process. And we've 12, and this is the first one bringing to the board.
Do we know how long ago this was?
Looks like 2013 to
Yes.
23-ish, 22 point something years. Yeah.
Yeah, and it was really interesting to read all the files for the application and their statements and their visits with their therapist and all the work they've done and how they had been a nursing student. And this was their spouse and in the car. They have a child together. It's really, again, to go back to the conversation we were having about expungement, it's a really interesting topic.
Do we have any question? Are we all good with this?
I guess how extensive was this mental health treatment and,
Oh, yes. Yeah. So We don't investigate what their treatment is. There's letters that come in to advocate for them.
And so, and then I'm assuming that we also we are saying that these were the last two convictions for this. Okay. Great.
Any other thoughts? No, we're good. Oh, so there's a motion?
And we didn't add the motion because I was doing this how you do it, but there should have been a motion, huh?
Yeah.
I'll I'm going to do that right here. And that was not our licensing manager's mistake. That was me thinking that we didn't need one. So my apologies. And based on the information provided, I recommend that the board approve this predetermination.
So moved.
Second?
Been moved and seconded. We'll do a vote. Matt Calzia,
Yes.
Rachel Dennis,
Yes.
Margaret Hill,
Yes.
Joni Kalis,
Yes.
Claire McKinley Yoder, yes. Rachel Mitzel,
Yes.
Felipa Nesta,
Yes.
Oleniki Toabola.
Yes.
The motion is passed.
Great, thank you all. And in a couple of minutes, you can announce the public forum and go from there. Thank you all.
Thank you. We are taking a break and we'll be back at Are we good? We're back?
Different ways. Love it.
Okay. Do we have anyone sign up? Okay. Should I still give my speech? We just wait. Six times a year, the board provides an opportunity for the public to make comments or present issues of general interest. This is not an opportunity to discuss investigations. The board would not deliberate on any issues or requests during open forum. The board president has the authority to stop any individual's comments when, in the opinion of the president, the comment goes beyond this directive or as necessary for efficient and orderly conduct of this meeting. Each speaker is allowed 5 minutes to speak. And we'll wait and see if we have anybody.
let me just wait for, there's a few people not in the room before I say, hey, we don't have any public comment. Might be the first time in a really long time.
We as a board decide we're going to try to advertise it better to our networks.
Yes.
Come talk to us.
And again, it is something that I regularly do when people write to us about stuff. I always let them know, happy, sad, mad, whatever, Brandy sends them information about it. I mean, I think we've been pretty busy at this public forum for a while, but it's so weird that we're all just sitting here quiet though while we do this as a public forum.
Staring at Gretchen.
Nobody leave the room again.
I know.
Front page of the paper, I keep staff hostage. So, Board President, you think it's okay since it's been 13 minutes and we haven't had any public forum that I jump in?
I think that should be totally fine.
Right, and of course, if somebody joins us virtually or walks in, I will halt my discussion. But I think many of you know that today is Gretchen's last board meeting as she moves into her well-earned retirement. I really want to take an opportunity to recognize her remarkable career and unwavering dedication to the field of nursing and nursing regulation. Over the past 15 plus years, Gretchen has served as a cornerstone of OSBN, which she's demonstrated exceptional professionalism, expertise, and commitment to public safety. Her extensive career, for those of you who don't know, spans multiple roles. So including her tenure here, which has been a role instrumental in shaping and interpreting nursing regulation. And prior to joining OSBN, she contributed her vast knowledge and skills at DHS and served as an educator at OHSU, helping to train and inspire the next generation of nurses. Her knowledge in nursing policy and practice has made her an invaluable resource, and her work has left a lasting impact on the nursing profession in Oregon. And her ability to navigate complex regulations provides sound policy analysis and support nurses through guidance and advocacy has strengthened the foundation of nurse regulation in this state. She is a dedicated colleague and mentor. Beyond her professional expertise, she's known for her collegial spirit and willingness to support her team. She has consistently stepped up to assist her colleagues, covering in their absence and ensuring that the mission of OSBN remains uninterrupted. And her mentorship and guidance has been instrumental in fostering collaborative and knowledgeable workplace. She's taught me so much. She's, I'm always kind of trying to play with the rules, and she's always reminding me what they are and to stay in them. I am going to miss her dearly, but we'll be keeping her on as a consultant, hopefully. I just really wanted to bring everyone together to wish her the best as she embarks on this new chapter and thank her. I know there's others in the room that may want to say a few words, and I welcome that. And of course, we have a beautiful plaque and pin and card and flowers. And I'm sure we will be gifting you with other things as we continue until your last day. But yeah, funnest memories with Gretchen are crowning her the Queen of Delegation at Nurse Learn and hosting her last Jeopardy game as Scooby and Matlock at our Christmas party. So, but yeah, I invite anybody else to say any words. And of course, Gretchen, I invite you to as well. And we also have cake. Look at that beautiful cake. It's ridiculous. Yeah. So yeah, does anybody else want to?
I do.
Please.
I just want to say we're going to miss you. You're fun. You're a great person you're a great resource. You're very patient in explaining, and even if we ask the same thing over and over, it doesn't phase you to repeat it. You might just repeat it a little sterner of like, I said it the first time, but I want to repeat it again. Just listen more this time. But thank you for all your knowledge. We are going to miss you. If you could just drop your brain in route, very helpful.
Oh, can I say something?
Yeah.
For you first? Okay. So obviously I've been here for 12 years working alongside Gretchen in the pits of policy. And we've obviously ridden the roller coaster, you and I, through rule changes, statute changes, executive director changes, staff changes, and illness. And you have been basically a guiding light for me, and have kept me grounded. And the amount of institutional knowledge that is walking out this door is incredible. And so I'm really grateful to know that you will still be available to us for consults. And also just to the state. And, you know, I don't think nurses get recognized enough. And I would walk into a burning building for this lady, and just know her heart has always been for this organization every single day. And I'm incredibly grateful for you, Gretchen. Thank you.
I'm gonna jump in now. You get it from two sides. So I have not worked with Gretchen for as long, only about 2 years, but she was one of the analysts who helped orient me when I started. And there is not a conversation we have where I don't walk away feeling like I've learned something from you. Like I'm always smarter because I've talked to you. And you know, when you tell me I'm wrong, I'm probably wrong. So I just, again, like it's such a loss for our team, but you have set such a standard that we have a lot to live up to. Yeah.
Well, I'll say I really have learned, just like you, Laura, so much. We're gonna really miss you, Gretchen. Like when I'm going through statutes or I don't understand, I'm like, explain to me what this actually means, right? In the workplace, or what this actually means as far as scope of practice. It's always Gretchen that first comes up because you can really clearly tell me the amount that we're losing here is, I just don't know how we're gonna replace it. It's you're incredible. Thank you.
It's not kind, it's the truth.
It's hard to say anything that hasn't been said. But Gretchen, and you'll read in the card I wrote, I'm so glad I arrived before you departed. And then I read it and thought, okay, I guess not a funerary card, but truly you have set the bar. And in the 8 months I've had the pleasure of working with you, you have been an inspiration. I too am grateful that perhaps we will have our claws into you a little bit more, even as you try to go have your retirement adventures. But not just in this role, but in my nursing career, you have been an exceptional mentor. Thank you.
I think the one thing that we've decided now is that she's going to retire, but we're all going to continue to call her. Right now.
She can leave her brain behind.
I'll see after her name.
So Nikki, you can just keep my phone over there. Okay, no, I'm just kidding. Turning on for your heartfelt comments. It really means a lot. And I mean, such kind words, but what I do, I couldn't do without all of you. With the extra knowledge, you know, the discussions, the back and forth, the what ifs, the planning, the alternatives, looking at all the options, and then coming up with what's going to be best to protect people that receive nursing services. Because As you all know, I am a regulatory geek and I will continue to do that after I retire, but I am looking forward to doing a whole lot of nothing for at least 30 days. And ceased from paying Social Security tax since 1975. So thank you, everyone. This means a lot. And I would say more, but we can wait till after we get out of public session and I can continue.
Thank you, Gretchen, for all your years of service to the state and to nursing and mentoring so many along the way and making us laugh also along the way. And we will celebrate you with cake. And I will bring your gifts since you're sitting over there. Thank you.
So we will be going on a break and be back at 11:15 for lunch and learn. I think we may be ready for our lunch presentation. I'll let Jana take it over.
Well, good afternoon, and thank you so much for having me come speak to you today. For the record, my name is Jana Bitton. I'm the Executive Director of the Oregon Center for Nursing, and I'm really grateful and excited to have this opportunity to come speak to you today, not only because I want to share the recent research that we've put together about the trends that we've been seeing in Oregon's nursing workforce, but also to be here for Gretchen, who is a former OCN board member. So I'm very grateful that I was able to be here on her last board meeting, and even though it's her last board meeting, we will not see the last of her. I'm certain of that. I also wanted to recognize that OCN we have brought our entire research team. And so behind me is Dr. Richard Allgeier, who is the author of the report that I'm going to be talking about today, and also is our new Deputy Research Director, Dr. Zen Keck, who has joined. What, are you 2 months in now? 1 month in? 1 month in. 1 month in, and we're really excited to have her. She's got an amazing perspective on on social work, on DEI, and PTSD. So I think that some of the perspectives that she has in her past work is really going to be applicable to the work that we're going to be doing with nursing. So what I'm hoping to do today, because I understand that I am the last on your agenda, so that means that and cake. That means I do not want to stand between you and cake and also whatever it is that you need to do for the rest of your day. So what I'm hoping to do today is just go over this for you know a little bit more about the things that we have learned, and then have you be able to ask some questions. And if you don't have any questions and you want me to speed it through, just let me know, and we can get through this just as quick as possible. So let's see if we can make this work. Or no. Or maybe. There we go. All right. So let's start here. One of the things that we do at OCN, as you all know, is we take a look at the data that is related to the nursing workforce so that we can give you information that helps you make informed policy decisions. So one of the things we really look at is the supply. So we were looking at the supply of registered nursing and growing. Right now, registered nurses in Oregon are growing at about 2% annually, and that's in line with national trends. Just for context, just when we think nursing is growing, I was looking at the employment department and some recent reports that they had, and it showed that non-farm workers in Oregon, those jobs are growing at 0.3%. So if nursing is growing at 2% annually, you can see that nursing as a profession, it's really keeping in line with national standards, and it's pretty solid as far as the growth that we can expect it to have. When we look at how many of those nurses are practicing, that's growing by about 1.6% a year. And you probably, I know that you've talked to the Oregon Health Authority. I know the Oregon Health Authority has come and spoken to you about the healthcare workforce reporting program. This data comes from that. This is one of the things that we analyze when we're looking at nursing workforce. And I'll get into the practicing so that you kind of understand where we come up with practicing. We want to take into consideration that not everybody who's licensed to practice in Oregon is actually practicing as a nurse in Oregon. So we have estimates about that. But you can see this, it's ever since 2022, we've added 2,970 licensed and 1,800 practicing RNs. And that's just in a 2-year period of time. So it's growing. That's not the headline. Here is the headline. When we look at the nurse practitioners, that is really growing. So the 2% growth that was happening with registered nurses kind of pales in comparison to the 15% growth that is annually happening of nurse practitioners in the state of Oregon. It's a smaller amount. I mean, if you look and you can see from 2022, we were going from 6,699 licensed all the way up to 8,855 licensed. So it's a smaller amount of people, but as far as we're talking about the percentage of growth, nurse practitioners are growing quite a bit. When we're looking at the practicing rate, we can see that the growth of the nurse practitioners who are practicing in Oregon is growing at about 2.3% per year. What is so interesting is that nationally, they anticipate that the nurse practitioner workforce is going to grow by 40%, but it's going to take 10 years to get to the 40%. If we're growing at 15%, and that's what our growth rate is going to be for the 15 years, it may or may not be, I don't know. We're kind of on the way to meeting and or exceeding what that's expected to be for the entire United States. So that's very interesting. The Oregon Employment Department lists nurse practitioners as the fastest growing profession that they anticipate to be happening in the next 15 years. And just as an aside, because I thought it was really interesting, of the 15 fastest growing professions in Oregon, 8 of them were healthcare related, 9 if you count veterinarians, which they do. I don't know. I'm a little on the fence about that one. So you can see we've grown. We have added, if you really think about the number of people that we have added in nursing, in registered nursing, we added 2,970 licensed, and in just nurse practitioners, we added 2,150. We are really growing our nurse practitioner workforce in Oregon. Registered nurses are continuing to migrate to Oregon. I know that I have shown you this chart before. What really makes me kind of like laugh, but not funny, haha laugh, and more of the, wow, this is crazy, is that we have been observing this change of the number of people that are migrating into Oregon to be nurses. We've been watching this since 2016. I think it was 2018 that I started to bring that to your attention, but it has just gone up and it continues to go up. I think a lot of people were saying that, oh, after the pandemic, it'll start going down. Not yet. It still is going up. We are noticing a lot more people that are migrating into the state. About 73% of newly licensed RNs obtain their licensing through endorsement, meaning they were educated outside of the state. So what that is showing us is that for every 1 nurse that we graduate from a nursing education program, we're bringing in 2.7 people from other states. It's a lot. There's a lot of people that are coming in. So when we take all of that together, we look at how many people that we have when we're looking at registered nurses specifically and staff nurses, because a lot of times when we're talking about policy, people are looking at the staff nurse level. And if we look at that, the number of people that we're bringing in as newly licensed nurses is exceeding what the Oregon Employment Department is anticipating that we're going to need. And this has been every year over the study period, but this has been over this phenomena was happening before the study period. We're bringing a lot of newly licensed nurses into Oregon. This should not imply that every employer that is in the state of Oregon is having an easy time finding nurses and they're everywhere that they need to be. That is not happening. But what is happening is that we don't have a statewide shortage in the way that it's been defined over the last 25 years or more. We have a completely different nuanced situation. So one of the things that I want you to notice here is if we look over at, like, just to give you a sense of it, you look over at the practicing nurses for 2024, you have 4,980. That's how many we are estimating of what we need, of how many we're bringing into the state every single year. And we estimate that the Oregon Employment Department is projecting that we will need 2,828. So that means just registered nurses. We're just looking at registered nurses, not the headline of the nurse practitioners. Just looking at registered nurses, we're going to need 2,000. We have more than 2,152 human beings who are legally licensed and skilled to practice nursing that are coming into our state than we actually need. So one of the things that I want to kind of just really briefly go over, and for this, I'm really glad that Dr. Allgaier is here. So if I completely biff this up, then he can come up and explain this a little bit better. When a nurse licenses into the state of Oregon for the very first time, either coming in from endorsement or coming in through an exam, like they go to nursing school here. They register for their nursing license, but they don't take that OHA test or that OHA survey that the Healthcare Workforce Reporting Program came and talked to you about. They only take that when they relicense. So we have this whole group of people, and you can see by the data, that group of people has been growing over the last 2 years. This huge group of people who don't give us any data about where they work, what their ethnicity is, what their highest level of education is. We don't know what that is. So they came up with a statistical math problem or math solution for this, where basically they go through and they say, okay, of all the people that took the workforce survey in the first place, what proportion of them are staff nurses? It's about 82%. Okay, then all the people who got licensed in that same period of time that hasn't taken that survey yet because they're brand new, what proportion of them are in there? And then they figure that all out, do the math, and that's how we figure out who we estimate are actually practicing. There's a lot of people that are not practicing. I mean, you run into this all the time, where there are nurses who continually make sure that their license is up to date, but they aren't actually practicing nursing. They're taking a break or they're retired. I'm sure that this is not going to happen to Gretchen, but they're retired and they're not actually practicing nursing, but they want to keep their nursing license, or they haven't let it expire yet and they still have to wait until their next renewal. You have new grads from other states that try to get licenses in many other states just to have it in case they get a job, and then they don't actually come. I think that I've heard on more than one occasion, not necessarily just in Oregon, where a widow of a nurse, just as solidarity to his dead wife, continues to renew her license, even though she's passed on, but they do it as solidarity. And that is beautiful and touching and terrible for nursing workforce data. So there are many reasons why people don't practice, but this is what we use as kind of our proxy to get an idea of when we are trying to figure out how many people are in the state who might need nursing care, how many actual people are actually doing that, and we can't necessarily look at the license. Does that make sense? Did I explain that correctly? Okay, God, thank you. This was the one thing that I was like, I don't know if I'm going to explain this correctly. Here's another thing. May not be the headline, but this is a sub-headline, which I think is really interesting. We have a stable multi-generational workforce. In the 2024 NCSBN Workforce Survey, they found about 40% of registered nurses say that they were intending to leave or retire from the nursing profession within 5 years. That's an alarming statistic. If you think that you're going to lose 40% of your workforce in the next 5 years, they are intending to retire or leave the workforce. That is a little bit nerve-wracking and not true in Oregon. So the top graph is showing you what it looks like for 2022 to 2024. And you can see all of the squiggly lines are basically looking at, I'll look it over here so that you can see, they're looking at the age distribution of the nurses for each of the different years. And you can see that in the bottom graph, that's looking at 2012 to 2018. And we were all over the place. We had young nurses and then we had a whole lot of old nurses, and it wasn't really distributed the way that it needed to be. Now what we have is we have an amazing opportunity where we have a multi-generational workforce, where we have about the same number of young people, and we also still have older nurses that are still in practice. The big silver tsunami that people have been talking about, that happened in the 2010s for us. But that is not true for other places. And when you hear a lot of data, national data, that's talking about the number of nurses that are going to be retiring, it's important to note that that is a nuance that isn't really bearing out in the data in Oregon. So it's fascinating when you think about what other people are talking about and how they're saying, like, we need to prepare for all of these nurses that are going to be retiring. That's not the narrative that is happening in Oregon. That demographic emergency that other states are facing, we are not facing that emergency. So now that 40% of nurses who say that they're going to leave the profession or retire from the profession, and 40% of them say they're going to leave in 5 years, that doesn't take out the nurses that are going to be leaving the profession because of burnout or because of workplace culture. Oregon is not immune to those problems. We do know that the nurses that if they're going to be leaving, it's less likely that they're going to be leaving because they're going to be retiring and aging out of the system. And if they intend to leave and they're saying that they intend to leave, it's probably going to be more related to workplace conditions, burnout, and some of the other stressors that nurses face. Educational attainment. So does anybody remember 2010 and the Robert Wood Johnson Future of Nursing Report? Oh my gosh, I never thought we'd get to this day, 16 years later, where I get some nods and some people are like, I mean, kind of. So there was a moonshot. When that report came out in 2010, they took a moonshot and they said that they wanted to have 80% of the nursing workforce in the United States of America to be BSN educated. Yeah, we didn't quite get there. But honestly, I don't think that there was any state that actually did get there all the way. We did pretty well though. When we look at the highest level of education for registered nurses, you can see it's growing slightly for BSN, and it's growing very, very, very slightly for master's degree. And it is growing for the number of nurse practitioners that are going on to get their doctorate. That is also growing. So we're getting more nurses that are becoming BSNs. We are getting more NPs that are getting their doctorate. What we are also seeing is that there are less nurses who are saying that the ADN is their highest level of education. So that is also showing that ADNs are going on and they're getting their BSN and getting more education. The message that has been shared for the last 16 years about how nurses need to really increase their education, they got the message and they are getting the message and they're continuing to increase their educational attainment. Here's a little bit about that educational progression to kind of go into that. So about a third of the RNs who hold an ADN at initial licensure have gone on to get their BSN. So they are getting more education, and about 7% of RNs that are holding a BSN at initial licensure subsequently go on to get a master's or doctorate, with 71% of RNs held a BSN or higher in 2024. So we didn't get that moonshot of 80%, but we're at 71% with a BSN or higher than that. So we've got a pretty well-educated nursing workforce. So let's talk about distribution. Like before, when I was talking about how, you know, we have the number of nurses that are licensed to practice, that are here for the jobs that we project that we're going to be having. This is a place where healthcare is going against economic trends. And we need to keep this in mind because nurses exist, but they're not evenly distributed. We're going to have more nurses in the Portland area than we are in Eastern Oregon. We are going to have more nurses that are going to go to a hospital setting than to an out-of-hospital setting. OCN has done an enormous amount of work on this to try to determine where they go. And so we know that that's where the gaps are going to lie. It's going to be in that geographic isolation and that practice-based setting. That's where the gaps are going to be lying. What's so interesting is that if you look at what the economic trends are in Oregon and in the United States, healthcare is kind of going against every economic trend. Most of the industries and the job industries in Oregon, manufacturing, construction, timber, all of that, those are either flat or declining. They're not really growing very much, but healthcare as an industry is growing pretty significantly. And specifically, when you think about rural places that really have relied on timber industries, manufacturing industries, and that sort of thing, those industries, we are seeing that even though those industries are declining in those areas, the population in those areas are aging and the demand for healthcare is increasing in that area. What we have not figured out is how to get the registered nurses that know how to take care of that demand to the place where the people that are demanding it has to be. And so when you hear people come and say, oh my gosh, Oregon has a nursing shortage, we just don't have enough nurses, it might be advantageous to drill a little bit deeper. Where are you that you say that you don't have enough nurses? What's happening for you? Are you in an urban, if you are in an urban area and you're in a hospital and you're having trouble recruiting nurses, that might be some time to really look at your workplace to figure out, why are you having trouble recruiting nurses? And so it's a completely different, and I think that's what we have is a structural problem. It's not necessarily a problem of volume of the number of people who are qualified and trained to be nurses. There are structural problems that are keeping nurses from the places that they need to be, which is actually impeding the goal that we all have, which is everybody just wants everybody to be taken care of when they're sick. And they want smart people who have the information that they need to be able to take care of those people wherever they are, whenever they need it, for as long as they need it. So one of the things that we think about is that we have been talking about, and I heard Matt saying this before, so Matt knows, but one of the things that we know is that when we are in a situation where we have limited resources and we have the information knowing that our resources are going to become even more limited, it doesn't make sense to continue to pursue solutions that are just going to increase the volume and the number of nurses. We have to be really, really thoughtful about where investments are going to be going and what kind of policies we're going to be enacting in order to make sure that we're solving the right problem and not just trying to create nurses for nurses' sake. So, for example, if we think about some strategies, we need to really look at retaining nurses that are already in the workforce. If they are churning over and over and there's high turnover at different locations, that's something to pay attention to. We really need to look at the job quality, the workload, the culture, make those as workforce priorities. We need to start looking at the care settings that are seeing the greatest strain. So that is rural communities, long-term care, other non-hospital settings. Home health is a really, really big one. And especially if we think about what the investment that the state of Oregon wants to do with the Rural Health Transformation Program, they're really emphasizing behavioral health, maternal and child health, aging in place. Those are the strategies that they're looking at. Those are the right targets that they should be looking at because that's where the needs are going to be the greatest. We also need to build place-based solutions. The communities, especially rural communities, have to be attractive in order for nurses to go there and make that place their home. So if they don't have good schools, if they don't have job opportunities for their spouse, if they don't have Starbucks, I don't know, but the things that they need. We've also done an enormous amount of work on this as well. There is an opportunity where employers and governments and community partners and nurses can work together to really target barriers in communities like family supports, housing, livability in those communities. And it may feel like that's not a nursing workforce issue, but I'm telling you right now it is. We're not dealing with the volume, we're dealing with this nuance, and it's a good place to invest. And then finally, that age profile, that's an opportunity. The fact that we have this multi-generational workforce, that really provides us with an opportunity to invest in mentorship programs, flexible roles, because we know that the younger generation is kind of demanding a lot more flexibility in their roles, but allowing the opportunity for experienced nurses to work alongside newer nurses to do that knowledge transfer and make sure that we can have the stable workforce that we're going for. So in conclusion, our challenge that we have in Oregon is not that we have too few nurses. That is not true for other states. And I think if you look at national conversations, they are going to still bring up the idea of like, we've got a shortage and we need to get more nurses. That is beautiful and true for them. I don't know that that is true for Oregon. And over the last few years, and this report just kind of solidifies, we know that that is not true for Oregon right now. So the solutions really need to be about whether nurses are in the right places, whether the work environment, the community conditions are going to make them want to stay. And if we can start pursuing those solutions, I think that's going to get us to the workforce that we are really looking for. Any questions?
Thank you for your presentation. Thank you for your presentation. I'm super excited about that work, and I definitely have a lot of ideas, but just to share one, I think that there's traditionally nurses have been kind of trained to be employed.
Yes.
And I really feel like there needs to be kind of a shift in, especially with nurses going through school now, about potential for nurse entrepreneurs.
Mm-hmm.
Why not have nurses that run and operate long-term care facilities? Why not fill some of these voids and these gaps with nurses, but train them to be entrepreneurs and leaders?
Mm-hmm.
And what does that look like?
Yeah. Agreed. It's hard when you think about what is the curriculum and what are the requirements for undergraduate work. There's so much that has to be just condensed into that learning. But after that learning and after they get that registered nurse license, there's so much opportunity to learn about entrepreneurial. I know that there's been a huge uptick of nurse coaches in Oregon, and they kind of define that in a lot of different ways. But there are opportunities for that. It would be great if there were some more training for nurses to be able to pursue those.
Yeah, and starting my own business myself, there is a huge learning curve on how to interface with other agencies, such as the insurance companies.
Well, and like,
That
you know, business, like trying to get your business license, trying to interface with that, that's not something you're nursing. There's no reason for nursing in your nursing program to teach you how to apply for an LLC or how to apply for a business license, but it's a challenge for some.
Well, how to get paid. I think that we don't focus on that at all. But what is your value?
Right.
What is the hospital actually charging for your services?
Yeah.
We have no insight into that. We're completely blind. So by not kind of shedding any kind of light or opportunity to learn about how nurses are paid, what is their value, we keep people as employees. We don't allow them to rise unless they are unique individuals that seek that information out on their own.
Yeah.
That's a great perspective. Great lecture. Thank you. It's a lot, and it's a lot on schools. It's a lot on new nurses. That the focus is just like, I just want to survive right now. There's that survival mode, and that's why it also takes nurses a while to kind of get into the job and understand what exactly am I doing, or am I just zoning through? And it takes time, mentorship to say like, okay, I could expand my role and do a lot more. But this was really helpful and great thoughts.
Yeah, thank you.
I have a question about the data.
Yeah, of course.
You know, Oregon's not part of the multi-state compact of licensing.
Yes.
And a single multi-site labor stoppage or strike requires thousands of out-of-state nurses to come in and become licensed. And as we know, labor stoppages are becoming more and more frequent, especially after over the last 2 to 3 years.
Yeah.
Could that be contributing to what appears to be an excess of licensees versus those employed, or has that been accounted for?
I think yes, and it could, but also keep in mind they're relicensing. So if there's somebody that's coming in just to be able to do the back work or to backstop for a strike, after 2 years, you would expect them not to relicense, and they are. So that tells us that yes, that does account for an uptick. I know that when Providence went on their multi-site strike, there was a huge uptick in work for the Board of Nursing with the number of people that we were trying to get licensed. And a lot of those people they're not relicensing again. But what we're seeing with this uptick and this trend, they are relicensing. So if they really are here just to be able to be here as a temporary measure for a strike, they're continuing to be licensed here. And we are tracking those that are coming here from out of state or getting their licenses from out of state, but don't have a home address here and have no work address here. And so we're able to kind of keep an eye on that. Even with that, even with those increases, there still are more people that are coming.
Great, thank you.
Oh, you're welcome.
I have a question about the migration. Do you see other states? Do you compare to other states, like their inflows and outflows, and how do we compare to those?
Yeah. So what's interesting is that it's very, very difficult to compare states that are part of the multi-state license compact. So that is one of the downsides of Oregon joining the compact. We would not have as much data on the number of nurses that are endorsing in from out of state because we wouldn't know that they were here. So when we look at the states that are not part of the compact, it does seem like we are getting more. We have more people that are coming in here. I can't really give you a specific number, and I'll look it up to see if I can, just as a comparison to say Hawaii or to, I'm trying to think of there's not very many states that are not part of the compact anymore, to just see what that rate is. But when we talk to people, we know that there's a lot of reasons to come to Oregon and practice as a nurse. We have the nurse staffing law. That is an attractor. It's also an attractor that the statutes and the laws are really, really friendly for the most part for nurses that are practicing. Nurse practitioners have full scope of practice here. So that's an attractor. And it's really beautiful here. And we're kind of nice people. So, I mean, there's a reason why people would want to come to Oregon, and they are.
A comment to that.
Go ahead.
You have a comment. To that, I would say when I was in the ICU and we were doing COVID, you know, we got so many traveler nurses here, and I can say across the board, we probably kept like 90% of them here.
Yeah.
One, because yes, it's beautiful, and they said everyone here is nice. But two, where we're at, like the benefits that you get, you know, they'll help pay with education. We get paid the most. They would say, we get breaks here.
Yeah.
And it's crazy to hear that. So, you know, people know I love to travel. So they're like, are you going to be a travel nurse? I was like, heck no. I would stay here, work some overtime, and take trips outside of here, just because the feedback you hear is that it is just so good here.
Yeah, exactly.
So yeah, the one question I did have about your presentation, when the numbers came up for the NPs, that we have such a high number of them doing that, do you feel like it's because people want to move away from bedside and be more like on the education part of that as an NP?
Do we have data on that? No. Okay. I would say, I don't know that we have data about people wanting to move away from the bedside. I do know that when I talk to nursing students, almost every nursing student that I speak to say that they want to go on and become a nurse practitioner. And I think that they want to do that because, again, we've really created a culture of expanding your education and not stopping. So I think that that's what happened. Now, do they actually do that? No, they don't actually do that. But I think that there is a push of more people, at least in Oregon, the ones that I've been talking to that have been educated. I think that there is a growth there because they want to continue their education. Keep in mind, though, we have a lot of attractors for nurse practitioners with the fact that we have a full scope of practice. And we also have a need, especially with psychiatric mental health nurse practitioners. We have a really strong need for them. So there is, I think that there is a desire for people to come in here. And hold on, because I think I said something wrong. Oh, I forgot. Oh, yes. Thank you.
You're welcome.
Yeah, thank you. The rate we pay registered nurses is actually really high. So in the state of Oregon, pretty much over the years, we're always in the top 5 of the states that pay nurses really well, which is wonderful. That's exactly what needs to happen. If you take it along with the cost of living in the state of Oregon, we rank about 18th because it is pretty expensive to live here. However, you know, when you've got nurses in some parts of the country that are making about $20 to $25 an hour with a registered nurse license, and they come here and making significantly more than that, it is a big attractor.
Thank you so much for this. And one thing I was thinking that kind of goes along with my comment is in acute care settings. Because I think also some nurses that are like represented and they're in big systems and they work in primary care, they might be making a similar amount. But I was really focused on what you were talking about with rural and long-term care. And I think about, you know, long-term care, a lot of times they're more independent. And so to go into that initially, but then long-term care settings have like 400% turnover. It's, you know, in some places. And so, and also the rural healthcare transformation grant, I know like school nursing in some very rural areas, they're doing kind of a model where there would be like more mentorship and support.
Yes.
But it seems like if we could come up with some models so that we could, because to be a new grad nurse and to be in like a lot of community settings is you're pretty autonomous.
Oh,
And
yeah.
so, you know, that kind of support, which you get if you work in a hospital, but we also want those people who want to work in rural settings and more, you know, autonomous roles and things like that. And so I would love to see if we could identify some really good models so that we could make it so that those folks who want to work in rural settings could feel like, okay, I can do this. 'cause
And
I
be
have what I
supported in
need.
that.
Yeah.
Yeah, that's a really good point. I think that over the many, many decades of nursing education and the way that we put nurses together and train people to be nurses, we really want them to be a generalist. And I think for, many, many years, the number one place that a new grad was going to start was going to be in a hospital. I don't know that that's necessarily how things are going. And I don't know that that's the future based on the data that we've been seeing over the last few years. I don't know that it's the future that the very first job you're going to get out of college is going to always be a med surge
I
job.
appreciate you're like speaking my language because
Okay.
I think that the way that NCLEX is set up, where
Mhm.
it does not have anything that has to do with it, like really population health,
Yeah.
leadership, those are not in some ways those are included, but it's really still feels like it has very much a med surge focus. And so, yeah, I think schools are trying to prepare people for that, like as broadly. And so thinking about like, yeah, how can we get more students into these community settings so they can see that full scope of the nurse's role?
And I know from the students that I have spoken to, it's, we have this model of education that does a great job at preparing nurses. It does, it works really, really well. And you have nursing students that will come out and they really are thinking that they have to get a job in a med surge unit. And that is the very first job. They need to do 2 years at a med surge unit. And even though I have watched educators work really, really hard to create clinical placements and clinical opportunities outside of the hospital as a way to expose students and say, here, this is what it could look like in long-term care, or this is what it could look like in home health or ambulatory care or outpatient or even infusion clinics. Look at how great it would be. And still the students are walking away with, I have to go work at a med surge unit for 2 years. And it has absolutely changed, at least in the Portland metro area, where most of our hospital systems aren't just hiring people straight out of nursing school. They're putting them through residency programs that really didn't exist like this 5 years ago. Our rural hospitals and our rural settings, they don't really have the resources and they don't have these residency programs. They are hiring people straight out of school. But if you don't have, if you have all of the nurses are being all of the most of the BSN programs are in the Portland metro area, this is where they are. They're going to try really hard to get a job in the Portland metro area when there's these other rural hospitals that could use them too.
Madam President, can I make a comment and ask a question?
Yes, please.
Thank you. So one of the things that you just commented on, and I know you're probably thinking about it, is, you are on Division 47 and Division 21 Rule Advisory Committee, and I'm talking to Board Member McKinley Yoder. We ensured some flexibilities around really encouraging students and schools to be using long-term care and community-based care for sites to really have that approach. And then in Oregon, we have Nurse Learn to really support those in long-term care environments to feel that support that our hospital nurses are feeling. So I do think and hope that Oregon is getting back on track to being a leader when it comes to community-based care, because we set national standards in so many ways and then just kind of, we're steady. And I'm really looking forward to having them come present to the board, because they had to kind of show what they've done over the last few years to maintain money from the state. And I think it's going to show that maybe there was less deficiencies. Nurses were happier, nurses were staying. So I'm really excited to have them back to have that conversation.
I have one question about the data.
Yeah.
Have you been seeing an overall decrease in the number of jobs available to nurses? And I'm only asking because I feel like I've been seeing more medical assistants take like office-based nursing jobs.
So I don't want to guess too much here. So I'm going to look at my research director. Do we know about if there's been a decrease in nursing specific jobs, or the jobs that we see is just healthcare social work? Okay.
The numbers are down some. The issue we're running into is we don't know how many jobs are with these postings. It's all we see from the employment department.
Yeah.
But yes, they are down. I would say fairly significant from a couple years.
Yeah.
say yes.
Yes, there are. They are going down.
I mean, when you say fairly significantly, like, is that like 90% or?
Not that much, maybe a third, which is a significant drop.
Thank you.
So you're welcome.
And in my best guess, just thinking about the big picture and the economic system is money saving, money cutting, and redesigning job descriptions to have more on certain job titles and kind of shift things around to save money currently. Great presentation. Thank you. It's always fun to have you.
Always
And
fun
we'll
to
get
be
it
here. So thank
while
you
you're
so
here.
much for having me.
Let me make sure none of our other board members have questions. And thank you all so much.
Right, I will stop sharing my screen. There we go. Thank you.
Do we have any other agenda items?
We do not.
Are we sure?
Are there some that you know about?
I have multiple pages of paper. I can make up something.
We do not.
Um,
I know it's pretty amazing.
okay, the meeting is adjourned at 11:56 a.m. and our next meeting will be June 24 and 25th of 2026.